For all those who are tuning in, my name is Patrick Oliver. I'm an emergency physician and have started MindPeace Clinics and have given grand rounds at UVA, and am very honored to be here at EVMS, albeit virtually, um, to give grand rounds, specifically talking about ketamine for the use of mood disorders and suicidal ideation, which is a relatively new development and definitively a revolutionary way that we can start thinking about treating suicide patients uh, in a very fast manner. Disclosures, obviously, MindPeace Clinics. I'm medical director and owner. We have three different clinics: one in Arlington, one in Norfolk, one in Richmond. And if any patients are referred to one of my clinics, I have a financial interest in these patients. I also work with clinical research partners, doing trials and helping, but I have no ownership. And I'm assisting with multiple clinical studies, including a COVID vaccine study that should be starting within the next week and recently hit the papers. Also, as a disclosure, ketamine is an FDA-approved medication and has been since somewhere around the neighborhood of 1970, but it's not for the usage of mood and anxiety disorders or suicidal ideation. But S-ketamine Spravato, which is 50% of the ketamine molecule that we give, is approved for MDD and NDD with suicidal ideation or gestures, which is new as far as the 31st of July. They got a new secondary indication, which is the only thing approved by the FDA to treat suicidal patients that are not schizophrenic, to the best of my understanding. Ketamine is a dissociative anesthetic. If you give it at a very high dose, the simple version is that it's going to put people to sleep. At a low dose, we've been using it for pain for several years in the emergency department, anesthesiologists, etc. And it's was found out, I believe, in somewhere in the neighborhood of 1983 to be an NMDA receptor antagonist that was moderate. And you can see that ketamine is an interesting medication because it has a lot of different things that it does and receptors that it interacts with. It's also on the World Health Organization's list of essential medications, but was classified as Class 3 by the FDA in 1999, likely secondary to a fair bit of abuse in the rave culture in the late 90s. The one thing that is also very interesting and kind of one of the linchpins of ketamine's success at the rapidly treating mood disorders is the fact that it works on the glutamate and GABA modulated systems and neurotransmitters. And you can also see the full dosage information and at basically the FDA. And I put that in there for your reference. Carlos Zarate, I think, really summed it up very well here. He is the primary investigator at the National Institutes of Mental Health and has been there publishing since 2006 on this topic. And I think he's exactly right. We need to think differently. And we need to be game changers. And with the rapid, what I'm going to show you, and it's backed up by the literature, the rapid change in how people interact with the ketamine and the rapid and profound within hours change of their depressive symptoms and suicidality, I think really makes a very compelling case. That was kind of an explanation was put on by the FDA when they approved it for suicidal ideation. This is going back to Dr. Zarate's study from and work in 2006. You can really see, I mean, so we're talking, what, 16 years ago now, that when you take a look for the ketamine response at one day, it's at 71%, versus your more traditional SSRIs, nortriptyline, venlafaxine, etc. At 8 weeks are still in the 13, 17, 20, I mean, you're talking a third and or less, at this many weeks in. Um, and so that's how profound a difference that this is, um, that we're talking about. So you go over the neurobiochemistry, and you can see that there's increased glutamate signaling, and decreased GABA signaling. So the way, as a simple emergency medicine physician, that I do is I think about this as it increases the glutamate, which is kind of the gas in the car, and decreases the GABA, which is the brake. Um, and also has monoamine, serotonin, norepinephrine, dopamine signaling, that's even recently, within the last couple of months, starting to be described, in mouse models. Um, you can see NMDA receptor, but I think it's more than just that, because there's other NMDA receptors that do work, and they just don't have the efficacy. So I think it's between that and an example of AMPA being activated. Glutamate ion channels found in the CNS, the prefrontal cortex, and the nervous system. I mean, we're talking about literally regrowing new dendritic spines, synaptic signaling, plasticity, learning, and it's really kind of an interesting approach to how we're treating depression in a very rapid deal. You're going to have increased glutamate release, decreased GABA, like I mentioned. It's an AMPA agonist, so while it blocks NMDA receptors on one hand, on the other hand, it's activating AMPA, as well as several other things. And then the downstream effect is that you're going to increase BDNF, and so you're going to increase synaptic spine interaction and communication in the prefrontal cortex. The things that kind of get involved with this are lamotrigine, which is a sodium channel blocker. It will literally block the efficacy of ketamine. And there was one published case report of an overdose on lamotrigine, and the person couldn't be sedated with ketamine secondary to that. There was a very small study done in Stanford, I believe it was published in 2017, saying that Narcan basically interrupts how the ketamine works. And chronic use of alcohol is also an issue, as far as that's concerned, along with chronic benzodiazepine use. Both of those are relative contraindications, and we're talking more than 2 drinks a day. And with benzos, it is higher doses that we're concerned with. This is really kind of where the action's happening. This is obviously it's rat neuronal tissue, but has been validated in human studies as well, and functional MRIs. And you can see the top, which is pre-treatment, and then the number of dendritic spines is not very much. You can see 2 highlighted. When you go to the bottom picture, you're going to see that there's multiple spines. They're bigger, so there's more interaction amongst the different neurons. So, I mean, this is a pretty profound change in the way we think about how the brain works, and that there's actually like branches on a tree. If the branches die, there's no signaling. If there's no signaling, it leads to depression. The published research goes back to 2000 at a small little university in Connecticut called Yale, where they basically showed that they started having, because of the NMDA effects they believed at the time, a rapid decrease antidepressant effect. And then that was followed up in 2006 by Zarate. And you can basically see the evolution over the next essentially 20 years of the research that has been done, including coming up to 2017, where the American Psychiatric Association placed a consensus statement saying basically that there was robust, very quick turnaround of patients' depressive symptoms, and that it should be considered for use by psychiatry in treating depressive symptoms. Then esketamine, the way the FDA is set up, nobody was going to put the $400 million in for a trial of ketamine, which was generic, except for the feds, and they were doing it, but it was relatively slow. Johnson & Johnson took the right enantiomer of ketamine and basically did the studies and showed that it was also working, although not quite as well as ketamine IV. You can see the longer-term outcomes. So it's been not having any cognitive or long-term cognitive effects, published for 126 weeks. So you're getting much more than 2 years worth. I've been doing this since 2017. I've treated hundreds of patients, thousands of infusions, more than anybody else in the Commonwealth of Virginia, and am joined by 6 other physicians, both emergency medicine as well as anesthesiologists, and we haven't had any long-term negative issues. You also get to ketamine's mechanism of action, and then blood pressure hasn't really ever been an issue for us, although it can go up pretty significantly. So here is, you go over and we can talk about the consensus statement. And you can see from that that it basically says, there's multiple studies and it's true. And also, if you look at the component recommendations, I think it's also true. I mean, there's some very reasonable skepticism from the psychiatric and the medical community in general about using a medication like ketamine that has had an abuse history in the past, but we have not seen any addictive elements to it. There's no physiologic withdrawals, nothing of that nature. But I think we should be very careful as to who we select to give this medication to. And they need a full physical exam, review of past medical as well as psychiatric records and history, as well as an informed consent process, with the ketamine being still an off-label usage, but the S-ketamine being an approved usage. So very simply, when you're going in to evaluate a patient for this, you need a comprehensive diagnostic assessment, and a mental health professional, psychiatry specifically, is obviously well equipped to do that. Issues of psychoses, personality disorders, borderline, obviously can create issues with treating these patients. Histories of substance abuse disorders are concerning, generally speaking. That being said, we've treated cocaine addicts, recovering alcoholics, people who've abused heroin, etc., and haven't had any issues with people either seeking or having any other issues. We also are very thorough, and we do both urine and blood lab results, and so we've kind of taken a look as far as any other potential causes for that. So this is from the 2017 APA consensus statement. It says basically that there should be trained anesthesia providers, physician, RN, CRNA, that administer this. There are obviously plenty of psychiatrists who are doing this throughout the nation, and they do recommend that there is some training that does take place through anesthesia to avoid things, some of the very rare side effects. We also monitor on a Q5-minute basis blood pressure, heart rate, respirations, and an EKG Q5 minutes. So we just do a continual tracing for that. That's the same standard that's done in hospitals, both MCV and hospitals throughout the nation, for procedural sedation, which this definitely comes into that level. Laboratory evaluation, TSH and testosterone, vitamin D, medication levels, We also do a comprehensive urine drug screen for women who are pregnant and or breastfeeding. The element is basically a no-go for ketamine at this point in time. Exclusions: we don't treat in the actively manic phase. We don't treat in ideally we try to stay away from access to personality disorders or psychoses. Uncontrolled hypertension, especially much increase between 150 and 200 millimeters of mercury systolic become an issue. And then a history of clinically significant substance abuse or polysubstance abuse obviously is cause for concern, although not an absolute contraindication at this point in time. While almost a theoretical issue, glaucoma and recent ocular surgery can be contraindications for this because it can increase intraocular pressure. Intracranial pathology and increased intracranial pressures for the same reason. Responsiveness. Typical response patterns, really can vary by patient. I've had patients down for 20 years being majorly and severely depressed by PHQ-9 standards in the 25 to 27. And I'm going to show you, the first slide I'm going to show you is one patient who just got one infusion and has been better ever since. It really is pretty remarkable, but not standard, unfortunately. We do 6 infusions. And the reason we do 6 infusions is because 92% of people respond within 6 infusions or by the 6th infusion. We occasionally do a 7th or an 8th if people do start to, their mood starts to improve on number 5 or number 6 towards the end, but they don't get the 50% improvement. We would discuss that with patients as well. There's multiple scales that have been used both in the research and in clinical practice for doing this. We use the PHQ-9 just because it's one of the more rapid tests, the GAD-7, and the Columbia Suicidal Severity Rating Scale for our suicidal patients. The standard that we use is a 50% reduction and or decrease of suicidality, and we have, and the literature has backed up 70+% repeatable decrease in the patient's symptoms of 50% or more. So we're basically talking 3 out of 4 patients who are depressed, even in the moderate range, can have some pretty significant, within hours to days, responsiveness. We do treat the patient and not the number, so we don't have any criteria or eliminating their ability to do this previously. While I do this subjectively, there is a CADSS, basically a disassociative scale. There have been multiple conversations in our world that the disassociation, especially for your PTSD patients, can have pretty significant benefits from being partially disassociated. And that's going to, affect how they work as well. I basically kind of describe it subjectively as you want somebody to that, what we call the buzz tipsy level, but first waking up in the morning, if you've heard somebody's name and or somebody asked you a question, and when they asked you this question, you had a conversation or they answered you, but it took a couple seconds to respond. Sorry, that's what we're talking about.